challenge, and I think that spans age groups, and I think it's good that we have different age groups within the room, because I think when we talk about leukodystrophy, or when I talk about leukodystrophy, often I'm thinking about a very different disorder in paediatrics to adults, and this is one of those things that actually spans the spectrum. Not many of the conditions I look after actually present in adulthood. We transition a few patients, but this is a truly spectrum spanning disorder, and that does have some challenges with it. And again, similar to the AGS, we're in that remit now of trials and treatments coming in, but what does it actually mean? Now, where I'm going to borrow at the end of me talk is talking about, James is here and he's working on some of the cell modelling, and that's a really important part of how we move forwards in terms of treatment and discovery going forwards. So I think similar to before, classical Alexander's is really easy to think about, and hopefully is not missed. I think still is missed sometimes, but in terms of classical Alexander's, we're thinking about children that come under the age of 4, they've got macrocephaly, some behavioural change and developmental delay and some motor problems and maybe some seizures. Now actually, if I've just said to you motor delay, seizures, that's common to lots of paediatric disorders. So if you say those things to me as a neurologist, I'm hoping that I pick those up. How many people at the start of their journey see a neurologist? Almost none. You see your GP, your community paediatrician, or if you're an adult, you present completely differently, so we'll talk about that one in a moment. So you need somebody to think about it in, again, a non-specific. If someone's measured your head, that might help, because if someone says, oh, actually, your head looks a little bit bigger, that might help. There's a shorter list of things that cause those problems, and that might clue you in. But actually, if you're a very generic presentation at the start, someone needs to think about Alexander's early, to think about getting the scans, because that's really where we're going to get more clues and think about your genetic testing. What happens if you're not in the classical Alexander's group? What if you just vomit every day and have vomited every day, every night for the last 25 years? That's not unrealistic, and they've had adult patients in the adult service recently that have just vomited and never had any other symptom. They work full time, they have family life, they don't really have any movement problems. How on earth do we pick those up? And we'll talk a bit about that in a moment. There's the behavioural change, the seizures, the motor issues, the ataxia. So this is a broad spectrum. If they come all together in a constellation, we think harder. If it's one of those symptoms, I mean, I don't know how you do it if you have one of those symptoms, and I'm sure we miss many people. And I think that's really interesting. I was chatting to Charlie yesterday, who's one of the registrars in London, who is doing a PhD in Alexander's disease, and they're looking at the bioresource, which is a massive bank of information for patients over the age of 40, and they've collected, these are well patients, or well people, and they've got blood tests, genetic tests, scans. They found over 100 pathogenic mutations in Alexander's GFAP gene, and these are not VUs where you're like, oh, it's a spelling mistake, doesn't mean anything. These are things that they think cause problems. They've then pulled out those scans. They have scans that look like they have Alexander's disease. These are asymptomatic people walking around the country. So I think there's probably your classical Alexander's, which can start in the neonatal period through to 4 years and then 4+ years. There are the ones that have asymptomatic symptoms, 1 or 2 symptoms here or there, and probably are really tricky to pick up. And then you've got asymptomatic adults that may present in future. I don't think we've ever known this question to ask before, may never present. So what on earth do you do if you find a gene and think about treatment? And I think that's really tricky. So I think we currently label our typical Alexander's into 3 groups. So we have our neonatal onset disorders, seizures, hydrocephalus, so that's a bigger fluid space in the brain, and those children often have profound delay from the outset. We have our type 1 Alexander's, so presenting under the age of 4 years, and again with lots of those very similar symptoms of motor delay, macrocephaly or slightly bigger head sizes, seizures, behavioural change and vomiting. And then over 4 years, you can get all of the above, but actually often the presenting features are speech, communication problems, vomiting, and then motor problems. Often they're a bit wobblier, as opposed to having profound delay. And all of those can progress over time. We have some children that progress very rapidly, and then we have children that progress slower. I'm afraid I can't comment on adult progression because I don't do it. So I'm afraid that one's a bit out of my remit to pretend that I can comment, because I think I have had one adult patient with Alexander's who I transitioned quite late because I kept him for a long time, but he's now 19. I had for several years, and actually he is, of my experience, one of my best Alexander's patients, in the fact that actually at the age of 18 he was independently mobile, he had some dysarthria, but was able to communicate. He was able to get the bus to college with some support and was doing some life skills. And having spoken to other adult neurologists, I think that is slightly outside of the spectrum as well. So I think it just shows you, even in my limited experience, I've got some of that difficult ones already, but I can't. So I won't pretend that I can do more than that. So testing everybody in this room will be, sorry. Away from it. And so I think that's where we're going. I'm not sure I'm even confident enough we can do it on MRI scans, because at the moment, so that's the recognised type 1, type 2 or the neonatal, but I think they blur, and I think often the ones that you think present later, if you actually took a really good history, they probably presented earlier. So I don't think it's very accurate. The proposal is that can you use scans to delineate them better? I'm not sure, and I think my basis for that is when you do look into the adult population, actually the scanning in the adult population is very different to what we see in the paediatric population. So I think that might help us in paediatrics, but then we've had cases where I had some twins probably about 6-7 years ago who presented like Alexander's, one and then the other a year later, and we thought it, but we did our testing, we'd missed it, we didn't have a GFAP. They had most of the MRI features, but not all of. They've both got 2 slightly unusual features on their MRI, but they're identical scans. So they went to Maya van den App in Amsterdam. They said it's not Alexander's, and they're like, well, what is it? And then we found, doing some of our funny testing, they're missing one whole section of a GFAP gene. But if you do your normal genetic testing, you're looking for abnormalities in the gene. The gene wasn't abnormal; just a bit of it was missing. And it's only by doing a different tool or technique you could find that. So actually, if you look qualitatively at the data, well, the quality of the data is fine. It's all in the right place. It's all in the right order. So I think even with those ones, I don't think that MRI is standard enough that we'll be able to delineate them that way. But yes, what we do now probably isn't great either. So yeah. Yeah. And your patient looks different. So then, yeah. Yeah. So I still believe, I think a clinical definition is better, because if I go to a patient, they want to actually know what happens to my child, what happens to my family member. And I think if I talk about your scan, I'm not sure that's helpful, but I think people are going because it feels firmer, but I think that's probably wrong. I just think what we do now probably isn't right either. But you're right. Is there something else that helps us identify who does what with the scan change of the presentation? And we're looking quite hard. We're not quite there yet. And I think part of that is sort of the motor and the cognitive assessments. That's not something that's done as standard at the moment, but we are really keen, not just within Alexander's, but across the board, to try and standardise cognitive assessment and motor assessments across the service. So we've currently got a psychologist that is starting assessments at preschool age, so a set age. She's going to do pre-primary, pre-secondary, and then transition into adults, and she's going to do it across our leukodystrophy cohort. So yes, I'll be able to pull out my Alexanders within that and say, this is what my Alexanders look like. They may or may not follow a pattern, I don't know yet. We haven't got that information. But actually, I can also say, of my undiagnosed group, if I pull out this type of patient, they look like that. Because it's one thing to have a label and want the answer. It's an entirely different thing to not have a label at all. And so I think if we can standardise some of the assessments, and similar to I'll talk about biomarkers because that's a good point, but if we can just look at how we assess our patients generally, maybe that can learn lessons for both individual groups and more widely. And that's not something that is standardised yet. So Alexander's, the 2 scans on the left with the brightness. So Alexander's has a typical scan featuring. It's not there for everybody. So on this is a normal MRI scan. I'm going to stand on this side. This is a normal MRI scan at the age of 2 years. It's important to know how old they are because our myelin changes over the course of the first 2 years and probably up to 3 years. So we see some blackness here. Our myelin should go black. When you are born, your myelin, well, it's not really there because you haven't built it yet, but this area of your scan is white. So you start with lots and lots of white. Then over the course of the first 2 years, it becomes blacker in places it should become black, and it should stay black. What happens in all of our leukodystrophies, it means abnormal white matter, And you can have hypomyelinating, so you never change colour, and you always say abnormally white, or you get abnormal white areas in patches. And in Alexander's, typically, it's this frontal predominance. So there had been talk over the weekend about pattern recognition. It was one of our earliest pattern recognition leukodystrophies, because almost exclusively you have anterior predominance of your white matter damage and change, and then there are specific criteria about enhancement and other things. So if you need to do the right scan to get all the right criteria. If you're done in a DGH, often not all the right sequences are done. But even without that, if you do bog standard T2 imaging, you should be able to see anterior change, and that's really important. But if we're scanning our patients at 6 months, we're not going to see all of that. So how many scans do you do in a lifetime? I think that's tricky, but that's something that in the natural history studies now, they're doing a lot of lumbar puncture and a lot of scanning over time, whereas in clinical practice we wouldn't do those so frequently, because if you're not going to, it's particularly when you need a general anaesthetic, it's a big undertaking. And there's not, as you know, with the NHS, there's not that much resource to do regular scanning. So it's about the balance of what's right. So trials in the future. Now, there've been lots of other talk about this weekend. I'm not going to talk about it specifically, but there are trials in action. There are some still recruiting. There are some that closed, and we are waiting for results over all of those. These are ASO treatments, so they're intrathecal treatments that are essentially trying to modify the degree of, and trying to switch off the overactive, or I didn't talk about pathology and what happens, did I? Sorry, this is what happens when you do a talk in 10 minutes. So in your Alexanders, you have too much GFAP protein, and then that damages the myelin and the cells, and it's an astrocytopathy. So it's an astrocytes that primarily get damaged, and then it leads out from there. So it's trying to switch that off, that overactive GFAP production. But similar to all the other talks, if you get it later, it might stop more damage, but it's not going to fix your previous damage. I don't know. I was trying to get some sneaky previews on Friday about what the feeling was, and there wasn't. It's not there yet, I've been told, so I don't know what the feelings are. But they've obviously changed the recruitment over the past 12 months, and we're now recruiting under 2 years only, which is challenging because I think a lot of us don't pick up under 2 years. So it is coming. Now in Leeds we're doing some organoid development, so a whole part of pathway discovery and understanding what happens so you can get to a treatment is understanding how it works. And James in the lab, we've got cells, we've made GFAP variant cells, and we're making them into astrocytes, so we're growing brain cells from those now. And with that, the hope is that we'll be able to then trial different therapeutics on those. Now the first step is we've got loads of drugs in the UK already. What do those drugs do? I've got no idea. But if we put them in a petri dish, maybe we can work out some. Let's start with the low-hanging fruit and the easy options, and then it becomes more complicated going forward. So at the moment we're in development, we're growing. It all looks good actually, and we need to start working on the next steps of actually getting drugs to those cells to see what they do. So it's in progress, as with everything you've heard this weekend. I think there's a lot of hope this weekend, but there's a lot of progress being said as well. So there's hope, but maybe not quite now, this minute. Hopefully next year we say something different. But it's going forwards. Did I write anything else in my 10 minutes? No, that's all I wrote in my 10 minutes. Sorry, that was a very quick chat. Any comments or questions or anything that people want? Yeah.
I'll try not to ramble because I'll probably go off topic or off question, but it's quite long. So obviously we don't know anything really. So my very limited experience, and I am only talking about the adult version obviously because I know it's very different from the child version. One of the things I'd been given to understand was that it was very difficult to do any treatments because the symptoms are so different. And that although it's identified by the specific gene, it's actually the different bits within that gene being faulty that cause the different symptoms. Is there any likelihood that you'll actually change the diagnosis of what's Alexander's disease and sort of break it down more to say that actually the different bits, whatever they are, when you identify them, and this is probably towards your genetic thing. So we only know a couple of other people that have got adult Alexander's disease. So there's only 3 people we know, and they've all got completely different symptoms. We know one guy who has no physical problems whatsoever and only has memory problems because it's a different sub-switch. Sounding really stupid, sorry. And I don't know if it matters, but does it, because we've not, there's kind of no treatment because they don't know how to treat it because there's so many different variations of it. So is it worth splitting it out into other diseases?
So I wonder if it will keep being called Alexander's, and that's one thing. I'm not sure that it will, because I think, and this is my musings, I don't know if that's true at all, but you do wonder when I think Alexander's, people feel like they know what Alexander's looks like, and now we are learning that Alexander's actually looks nothing like that in some settings. So I wonder if the name will change, because we now understand more about the pathway. Do I think your diagnosis will change? I think probably not, because all of these conditions, regardless of what they look like at the end, are due to a problem with the GFAP gene that causes a problem with the GFAP protein and the Rosenthal fibres and causes symptoms. So I think the pathology is common, but the end result is different. And even within the gene, so we've got patients with the same spelling mistake that look completely different. So I don't think you'll even be able to narrow it down, because in some of the other disorders, you can say you've got a POLR3A, you've got a POLR3B, if you've had that mutation, you look like that. Maybe we'll be able to prognosticate better in future, and particularly in adults. I think in adults it will change, because I think this bioresource work is going to change what we understand about adult Alexanders in a way that we have never done. And maybe we'll be able to say, if you have this specific spelling mistake, you look like this, but you need volume of patients to do that. And Alexander's in adults is so rare, that's never been possible. Whereas I can sort of do a type 1, a type 2 a bit, not based on the spelling mistake, but based on the presentation. I don't think you've had enough adult patients to do that, but maybe with the bioresource work, actually, they'll be able to say, if you look like this, or you have this spelling mistake, this is what you look like. If you have this spelling mistake, maybe. But I think you need numbers to get there. I think the treatment thing's hard. I don't think it's not being able to treat it because you all look different. I think it's just knowing what the benefit of treatment will be is the challenge. So I think they are starting. And again, for the trial, you took any form of patient clinically, didn't you? You just had to have Alexander's. So we've treated a massive group, but they all looked very different.